Hello and welcome to the AHPs and Quality Improvement podcast, where we are on a mission to raise the curiosity and profile of allied health professionals in quality improvement. We will be delving into the very heart of what quality improvement means. We will be contemplating the power of networks and spotlighting great QI work that is happening in the AHP world. We will be looking outside of the AHP world to see who we can learn from and apply this to our day-to-day work. Likewise, you don't have to be an AHP to listen. Our best work is done in collaboration, and we want to harness the power of connection to improve the care we offer patients, the teams, and the systems we work in. Hello listeners. Today we are joined by Amar Shah and Naomi Burden. Naomi Burden is part of our AHP QI network and she is my co-host for today. And we are really delighted to have Amar here with us, who has been leading on the way on various quality improvement initiatives, both in his trust and his role, in his clinical role, but also in his national roles with NHS England. Amar, is it just okay if you introduce yourself and tell us about your roles at the moment?
Absolutely. Hi, Joe. Hi, Naomi. Lovely to be with you today. Thanks for inviting me. I'm Amar. I'm a doctor by background, so I work as a consultant forensic psychiatrist, which means that I see and support people who have mental disorders, but who've also committed offences. That's been my clinical training. And over time, I've also started learning about quality. And now my job really has a small amount of time dedicated to clinical work, but most of it is about leadership, really. So I'm Chief Quality Officer at a trust called East London Foundation Trust. We deliver a range of mental health, community health, primary care, specialist services to about 1.8 million people, with about 1,000 beds in total across our organisation. And here I've been adopting a more systematic approach to quality for about the last 12 years now that I've been here, which includes QI, but isn't just limited to quality improvement. And maybe for the last 7 or 8 years, I've been doing this work in the mental health field across the country through a role at the Royal College of Psychiatrists, where we lead large national improvement work and collaboratives and programs on topics that we apply quality improvement to. And in the last year now, working with NHS England as National Clinical Director for Improvement, which is a new role designed to help support the whole of the NHS to adopt and embed approaches to quality improvement. So a range of different roles, but all really about trying to improve care.
Fab. So from when you were a forensic psychiatrist, what sparked your interest in quality improvement and looking at how we can improve things for patients and those groups we work with?
Well, in some ways, it's a bit of a sad story because, when I trained as a doctor and through my postgraduate training, I don't think I ever had any exposure to complex systems theory, quality improvement, even patient safety. It was very limited or none at all. And it was only really through seeing an opportunity to take some time out of clinical work. I applied for a 1-year out of program placement where I was going to work with the Department of Health and the Chief Medical Officer there, who was Liam Donaldson at the time, in learning about policy, and part of that role I was also with the National Patient Safety Agency when it existed in 2008, 2009. And that was my first insight really into the world of safety science. Never really been exposed to it up till then. And I was, a couple of years away from being a consultant, never heard of improvement science or safety science. But that really opened my eyes to the opportunity to not just be able to influence the person in front of me on a one-to-one basis, as I was as a clinician, but to also think about the system in which I operated. And really from that point onwards, I haven't ever been a full-time clinician. I've always practiced as a doctor, but I've also been trying to apply what I've learned about quality improvement to the system in which I've worked. So, it's a little bit sad in a way that it took time away from clinical work to get that awareness and insight that there was this thing called quality improvement, but it has dramatically changed my career, I think, from taking that time out as a trainee.
Yeah. So we have a shared love, I think, of safety and improvement. as many people in the AHPQI network do. And I just want to ask you, there's something about the conditions and the climate that's set for people in wanting to make changes, whether it's driven by safety or improvement science. And I just wondered if you had any thoughts on that.
Oh, I mean, I think it's critical, isn't it? I mean, I think the literature these days is pretty strong on the role of context as having a big influence on the success or not of improvement efforts, no matter which aspect of quality they're about. So actually taking the time to really understand the environment in which change is going to be happening, making sure it's as conducive as possible to that change is probably time well spent. And this applies not just at the team level. So if you're trying to improve something in your service, I think it's really important to understand, like, do we have the right ingredients to be able to actually improve this aspect of quality that we want to? And there are good tools out there now that we can use. So if you haven't found a way to do this already, I'd point you to the MUSIQ tool, MUSIQ, which is the model for understanding success and quality. It was first developed from a range of structured interviews and observations at Cincinnati Children's Hospital in the US, which is one of the world's leaders in improvement. And they came up with a set of conditions and factors which they found were really conducive to improvement happening. And you can use that now. It's freely available. You can start to look at, your own system, your own team and service, and say, like, how many of these are in place? How many of these might we need to strengthen before we start our quality improvement work or safety improvement work, and give it a better chance of success? But you can also think about that from a whole organization perspective, because if you're trying to introduce this way of thinking about problem solving and this way of empowering people to be able to identify and solve issues in their daily work, you need to create the right culture and climate for that to happen. So actually, even at the organizational level, really taking time to think about that and understand what's going to be the really core components is probably time well spent. We spent 2 years preparing the ground in East London Foundation Trust before we pressed the go button on our quality improvement work. And that 2 years was really about trying to make sure we had, good pipelines of staffing coming through from our universities, particularly for nursing and AHPs, making sure we had really strong clinical leadership across all of our teams. Those backbones that without that, you're going to struggle to really be able to improve if you don't have sufficient staff, sufficient leadership, sufficient capacity, all of those really core ingredients.
There's something, isn't there? And I think the MUSIQ tool talks to this, about having that diversity of thought and being able to work on different system levels, but also know who your experts as well that you can draw on, because improvement is a team sport, I think. And so those conditions that we set around us and within us as a team, they can be game changers. And it's really lovely to hear your reflections on that. So thank you so much.
Yeah, and obviously expertise. I mean, I think improvement, when you do improvement work, your view of expertise, where the expertise comes from, it probably will change, because we're quite used to deferring to seniority and certain professions in healthcare, and actually the way in which we work, sometimes our training reinforces that. But actually, when you're really trying to understand and solve quality and safety issues, the expertise around how to do that often comes from unusual places. I've had the privilege of supporting many teams to apply quality improvement to solve something that they really were struggling with, and teams have sometimes found the most valuable insights come from unexpected places, from people with lived experience of the service, helping them understand what works, what doesn't work, what might work better. But even on wards where people who haven't had a voice up till now, when they're suddenly involved in understanding what we could do differently, can come up with great insights. I remember working with a ward, an older adults ward many years ago, which was tackling the issue of physical violence. And the patient group had mostly functional dementia and got agitated occasionally, and that ended up as violence towards staff. And they were trying to work on what they could do differently. And it wasn't until they started to involve the domestic staff, the housekeepers, the cleaning staff on that ward, that they understood the importance of noise on that ward. And it was the domestic staff who helped the team really think about doors slamming, the ambient noise and of people's voices on the ward. so the team started to explore that and then tested some ideas around, how to dampen the doors, how to use a Yaka tracker in the middle of the ward, which monitors the decibels in real time. And by being more conscious about noise, that team was able to actually reduce people's agitation and reduce physical violence levels. So I think diversity of involvement, but also just recognizing that people bring different expertise. And we're going to rely on that. We're going to need to involve that to be able to really, truly understand the system.
Agreed. I think it's often drawing from the patient out and looking who's in the team rather than kind of organisational structures, which tend to bring in silos. One of my top tips from a QI practitioner that I worked with was to try not to defer to the hippo's opinion. And the hippo was the highest paid person. So the highest paid person's opinion, that's what hippo stood for. And I think that that's really good advice, because we do often, as you say, get lost in hierarchy and think about where is that knowledge of the work as done, and that can often come from a different place. And I think that's a really great example about inclusivity of thoughts and inclusivity of teams, to be able to solve problems together. Nice.
And it does mean that, the people with formal power, the people who often are the highest paid person in the room, or seen as the most respected or the most wise person, they have a slightly different role to play, don't they, in improvement? It's not that their ideas don't count. They do, because they bring a lot of wisdom and experience, but they also have a really important role to play in being able to encourage other views and ideas, to allow people to express their own thoughts, to allow the team to feel like they can experiment and learn when things don't go as they predicted. So I think that leadership role changes too, from having to be the person with all the answers to actually being able to be the person that brings the team together around shared purpose, encourages everyone to contribute towards understanding the issue we're trying to solve and testing ideas. I think that's in some ways quite liberating as a senior person to feel like you don't have to have all the answers, but it does take a slightly different style of working and interacting with the people around you.
That's a really interesting perspective. What qualities do you think leaders of quality improvement need to have or need to develop to do this work well?
Perhaps the most valuable characteristics I think I personally have found useful have been persistence, patience, curiosity, and approach to continuous learning about your own practice. I do think this is a long journey that you're heading down if you sort of want to try to adopt this way of thinking and working. And I found it useful not to get too caught up in either the successes or the things that don't go so well, and actually be able to see the long game. And there are a lot of frustrations in this field. There will be people who just don't accept it, believe it, don't want to work in this way. Some really key people, some key influential and powerful people who just don't think that this is the right way to lead and run a team or an organization. So persistence and patience are very important, but also just having the humility to continually reflect and learn and think about what's working, what's not, and adapt your approach as you go, because every context is different and there is no right recipe to do this. I don't think that there's some building blocks, but you have to sort of pave your own way with the people you have around you and figure out what will work.
So you mentioned there that some people can be a little bit, say, skeptical about the role of quality improvement. How do you address those concerns? Because I think I read a blog of yours where you addressed the fact that we seem to be seeing lots of jobs that have quality improvement sort of written as part of them, and it's turned into a little bit of the latest buzzword. So I think quite rightly there can be a little bit of pushback on that. So how do you go about addressing maybe some of those concerns?
Well, I think that's the risk, isn't it, with something feeling like it's the thing to do, either because you mandate it or people say it's important. Unless you truly understand it and believe it, then you'll be prone to do things like that, just adding quality improvement into your job title and still working in the same way. for example, or paying lip service to it. Just setting up a team and having them do some work over in the corner of the organization, which is obviously not the true intent. When you adopt improvement, it's a philosophy, it's a way of thinking, believing, working, interacting. And I guess the best way, I think, skepticism and resistance is to be expected. I think if we weren't encountering it, I'd be more worried. People have to be curious about something, have thought about it enough to actually be skeptical or to resist. That's a good sign. I think the best way to demonstrate this is through results. And if we can demonstrate that this actually works and makes a difference and is better than the alternatives, then people will give it a go at their own time and at their own pace. But I think the real risk is that we don't deliver results. And if quality improvement doesn't deliver results, people have a right to be skeptical. And there are places which say they're doing quality improvement, but really aren't. And I think, they shouldn't be surprised when people are skeptical. It's not a slogan, not a mantra. It's not something that we should just follow blindly. We have to be sure that it's going to be a better way of solving problems than what we had before. And the best way to do that is to demonstrate that it actually is, with real rigor and robust use of method and data.
Just thought the point you made about people think they're doing improvement and they aren't. There's a really interesting thing for me about what's the difference between change and improvement. And just personally for me, you're doing change if you already know the solution to the problem, because you would just get on and do that piece of transformation or whatever it is you need to do. But I think the beauty of QI is that it allows you to solve a problem and work out how you're going to solve the problem. That PDSA cycle meant that you didn't have to have all the answers. You just had to have the ideas that you were going to test. And I knew when I first moved into that space, I found that quite liberating a little bit, as you say, by being the leader. I didn't have to have all the answers, perhaps in there, but I could take some risks that perhaps I couldn't have taken before. And that's what attracted me to it, because I could do that in a very safe way with the sound application of QI science. And I found that really brilliant. And also I would just reflect on my own experience, and I'm sure others that are listening, about the messy reality of QI. When I first was introduced to it, I thought it was going to be something quite linear, almost like a waterfall change management project. And it's just not like that, is it? It's a squiggle, and you'll go forward and then you'll come back and then you'll go forward again. And I think honesty on that messy reality of it, and also how you can engage others within it outside of your own organisation to be able to solve problems is a real attraction.
Yeah, absolutely. I couldn't agree with that more. I mean, I think the key is to make sure we're learning as we go through that messiness, because we are solving some of the most complex issues, right? The things that we haven't found a way to solve up till now are the things that we apply quality improvement to. So they're not going to be easy. And we're going to make some mistakes, and we're probably not going to involve everyone that we should be from the start. We'll probably learn as we go how to do it better. So yeah, you're right. It's not always straightforward. And actually, in some ways, that's a nice way to reframe some of the challenges that we face today, because they're pretty daunting challenges. If you think about look in the media, what's being said about the NHS, there's not always a lot of positivity. There are huge waiting lists or financial challenges. There are safety issues popping up all over the country in different ways. Trying to figure out how you would run a high quality, safe, cost efficient service is not always straightforward. And when you're grappling with something big, actually quality improvement can be a helpful structure, because you break it down, you take it in chunks. You don't have to feel like you know the answer, but you've got some theories and you've got some ideas, and with some really good support, with some leadership attention, I think you've got a good chance of working your way through it.
So just having a little think about one of your national roles is with NHS Impact, and it's got some quite big goals over the next couple of years. Are you able to tell us a bit about these and also how AHPs can be involved? Because sometimes I think we do have a tendency as AHPs to sit back a bit and think, oh, this is a medical, this is a doctor and nurse sort of thing, and not get fully involved.
Yeah, so NHS Impact is a framework. It's nothing more or less than a framework, and it sets out the 5 components that organisations should be paying attention to if they want to truly adopt and embed a culture of continuous improvement. I don't think there's anything hugely controversial in it. It's been co-produced. It's based on the evidence. It's there for people to use and think about how they might incorporate. It is part of a real effort at the moment across the NHS to support the greater application of quality improvement as a systematic method. And I think that's fantastic, because I think over the last 10 to 12 years I've been working in this field, it's been a massive change from just a handful of organisations dabbling in this maybe 12, 13 years ago, to it now being very widespread across, especially across provider trusts. And I guess the ambition of NHS Impact is to support organisations to truly adopt this, to be able to deliver better results for their local communities, but also to support integrated care systems, to think about how they would apply quality improvement across big geographies and across multiple organisations working together to solve problems, and then to think about how we as a country in England would adopt quality improvement to deliver results on things that we all have a shared interest in much the same way that we've been doing this in the mental health field for about the last 5 or 6 years. We've worked on big, complex topics like restricted practice, like sexual safety, like workforce well-being, like inequalities, things that we all grapple with and don't have solutions to necessarily, but working together, we can learn faster and we can test quickly and show some results. And I think that's the ambition of Impact, is to accelerate both the use of improvement and the belief in it, and also think about how we would tackle some of the really big national challenges using an improvement method. I honestly, my personal experience has been that AHPs are brilliant natural improvers. And I don't know whether that's to do with the people who go into that profession or the way in which you're developed. But I have no doubt that allied health professionals are going to be right at the heart of this, and should see themselves as being at the heart of it. Because a lot of what I think or the way in which you already approach your roles, your clinical work, is not dissimilar to the scientific method. It's really about helping people set goals. It's about testing things out and measuring progress. It's not that different to how we take a more systematic approach to change through service, or trying to change services through quality improvement. And there's a real opportunity in this, I think, for people to start building their skill set, building their expertise in how to lead and influence change and improvement. For me personally, I started out wanting to be a doctor, and actually, my career has gone in a completely different direction. And I'm very grateful for that, and I've had so many opportunities and experience through that I think others should try too. One of the really lovely things to see has been just how the field of improvement has grown. 10 years ago, let me put it this way: every single job I've done in the last 10 years has not existed. It had to be created. But I don't think that will be the same for others who follow. I think there are many, many more improvement teams with clear career progression. Most boards of trust now have someone who's responsible for improvement, and there are increasing numbers of roles like mine, which are actually there to provide expertise on quality management at board level now, which I think should be mandatory. If we are here to provide quality care, that's our purpose in the NHS. So why would we have a mandatory finance professional on the board but no mandatory quality professional? It doesn't make a lot of sense to me. But there are increasing numbers of boards who are seeing the potential opportunity of having people who really understand systems thinking and quality management on the board. So I would say impact is just a framework, but I think there's a real energy across the country to see how we can strengthen and accelerate the adoption of improvement, both in organisations and systems, but also across the country working together to solve big problems. And I really hope, and I'm sure I will see AHPs right at the heart of leading this effort.
You know some good people. That, and thank you for your kind words about AHPs. I think one of my observations of us as a fantastic group of people is that we often underestimate our transferable skills of how we can operate outside of our profession. And how it works in others, and those that have more of that portfolio career or maybe delved into different roles really showcase that. One of the things that I wanted to just kind of jump to really was about talk about professions and that curiosity, because I think that's what AHPs have, and we often ask questions with curiosity. And it's part of our mission statement as a network. And I know something you've talked about within your blog. So how do you stay curious, especially when you're in such a busy role?
Interesting question. I think a couple of ways. One is by making sure, I mean, you're talking about me personally, staying curious, right? One of the things I try to do is to make sure I carve out time to just think. And that's quite hard to do. But I find that if I don't find time to just stop and reflect and think, I mean, that's the first step of being curious, isn't it? Just to be self-aware. So, just having time to think and reflect and then consider is probably the first step to internal curiosity. I also try to make sure I'm finding ways that fit into my working pattern to keep learning from other places. I think that's important too, because, there's some fantastic work in this field all around the world going on. And a lot of that is quite easy to access these days. So, finding ways to keep reading, keep learning, keep connecting to people, meeting new people. Because the demands of clinical work mean that, it's not always easy to find time away from that. But, if we can to think about what conferences might be the most useful ones for us to learn, who might be the most important people to connect with. These days, it's quite easy to make connections with people on digital platforms and actually start to make some interaction between us, even when we've never met in person. So I think to stay curious, for me, it's about just making time to reflect and think and finding ways to keep learning. I'm not sure I would ever say that I know everything I need to know in this field. There's always things that I'm coming upon that are interesting, that I want to dive into a bit more, learn about, go and see, go and read about. I think those are really important. I mean, I see this as a very practical, pragmatic profession, improvement world, which is why I think AHPs are really good at it, because I found AHPs to be very creative, very pragmatic, and that's improvement is about rolling your sleeves up and getting stuck in. But it's also about, working with others, building a team. Sometimes people have not worked together and finding common ground and making sure we're all focused on what we're really here to do, having that shared purpose. So I think those things are really helpful too. And when you're solving some of these really challenging issues, the more diverse the perspectives you have in the room, I think that helps you stay grounded, because you will learn things all the time. Even as a forensic psychiatrist, I think I know, a relatively good amount about the subject matter in my field, and yet, whenever I'm having a conversation with a patient, I'll be learning things about their life and their interactions with the services that I never even knew about, and that helps us stay curious. Continually finding things that don't work as well as they should. That constant sort of creative tension that we could be better, that helps us stay curious too.
I've certainly found that the quality improvement people are always sharing the interesting things they found, or have you come across this? And there's a really openness and a good spirit of collaboration, which is welcoming, and also is maybe something about the type of personality who's drawn to this sort of work that does have that innate curiosity. you've managed quite a few different quality improvement projects. Are there any that you're particularly proud of, that you'd like to tell us about? Any that you're particularly pleased with, and why do you think they have worked well?
Well, it's really hard to pick one over so many years. I think it is very hard. I think there'll always be some that stick in the memory, won't there? So when I was first learning about quality improvement, I worked with 3 older adult wards who were tackling the issue of physical violence. It was one of the first times we had tried to use quality improvement in our organisation in East London here. That will always stick out for me because the work we did on older adults and then adult wards, starting very small with just 1 ward, learning what it took to predict and prevent violence, and then taking that learning gradually over the next 4 years across all 50 of our wards, reducing violence across our whole organisation by 30%, ending up in the NICE guidance because it became seen as the sort of best practice in the field. All that work from so many people contributing to extending our learning about how to make wards a safer, more therapeutic, more recovery-focused place for people. I'm very proud to have been part of seeing that piece of work through. And again, I think more recently, seeing how in the wake of the pandemic, teams have been using quality improvement to tackle some really thorny challenges. In some of the national work I've been doing, we brought 40 teams together in 2021 to work on well-being, because at that stage teams were exhausted, they were working very differently, and actually most of the data from around the world suggested people were experiencing high levels of burnout. So we took those 40 teams, we ran a year-long program around well-being, giving them the tools of quality improvement and close coaching support. And actually those 40 teams, they showed improvement on all 3 of their outcome measures. They were enjoying their work more, they had fewer people experiencing burnout, they were more likely to recommend their team as a place to work, which is completely the opposite to the trends we were seeing in the rest of the country and the rest of the world. That's a pretty phenomenal finding, I think, in 2021, 2022. Now applying the same method to waiting lists and waiting times, which we know is such a big challenge. Have another 20 teams across the country, ADHD teams, autism teams, children, adolescent mental health teams, all working together to figure out creative ways to meet the demand better, quicker, and use their resource in ways to maximize their capacity. And it's been a joy to be part of that 18-month program. So I guess it's hard to pick 1 or 2 things, but what I get a lot of pride from is sort of being able to see people's excitement, from something that was a real burden, an increasingly long waiting list that's just getting longer and longer and longer, to actually starting to feel excited about that challenge. I mean, that is quite something, isn't it? For a team to feel like quality improvement has given them power to actually understand their system, do things differently, and actually they now have a bit of control now over the demand coming in, and they can see people quicker and people's waiting times are going down. I mean, that just being able to see people's transition as they have started to learn and apply quality improvement, that has got to be the number 1 reason for doing this work, I think, because it's pretty profound.
Oh, thanks for sharing that. I can just imagine, being in the situations where I haven't been able to do the work that we have wanted to do because of pressures like waiting lists and things like that, to take back some of the control of the situation and to be able to think, oh, we can apply some principles, we can actively move towards solving these problems, is just a huge change in mindset. I feel I've asked a lot of questions now. Naomi, did you want to leap in with one?
Not a question, more of an observation, really. I was just listening to what you were saying there, and I was just taken right back to the habits of an improver from the Q community, and the skills that are kind of mentioned there. So that co-producing with health and social care through communication, creativity, resilience for sure, because it's not that lovely linear line that we like to think there is. But the ability to influence sometimes outside of your sphere of control, and breaking the hierarchy chart. And I'm a bit of a good rebel, so that always resonates with me. But that systems thinking, how we accept change, how we synthesize information, how we see that bigger playing field. And for me, I'm quite simple sometimes in my visuals, but I always think about how cogs are fitting together, and if any one of the cogs is taken out or moves differently, what else does that do to everything else in the system? And really that continual learning, yes, the curiosity and the problem solving, but just as you've been talking about the thinking time, that ability just reflect. Thinking time is so hard to find, but yeah, I was just having a full loop moment there back to habits of the improver, which I know many people are familiar with from the Q community. And it's just nice to hear those in practice. I think that they're real living, breathing qualities that I look for with improvement. I suppose it's lovely to celebrate success, but I am a bit of a person who thinks I personally learn more from failure, and when things don't go to plan, which is probably seen within some of my other podcasts that I listen to about how to fail and so on. But I just wondered if you'd be kind enough to perhaps share when something hasn't worked quite so well, and what you've taken away from that.
Yeah, I mean, there's many things that we haven't done very, very well over the last 10 years, and things that I would do differently going forwards. I think the key is just to have a spirit of learning. I think that's the most important thing. What Amy Edmondson would describe as intelligent failures, where we're going into it with a theory and a prediction, and actually, if it doesn't work, we're learning and adapting our theory. That for me is the most important thing. There's many projects that, for example, just don't achieve their aims, and I think that's okay. When a team comes together and they want to solve a problem, they set themselves a really ambitious goal. They may get there, they may not get there. The key is, have they really been applying the theory of improvement? Have they done it in a robust way? What have they learned that they can take forward to their next effort? Lots of ideas people test don't work. Lots of people that we really need to believe in this often don't believe in it, and we have to try lots of ways to influence. And some of those efforts work, some don't. And it's a pretty, there are probably more what you might describe as failures in this work than there are successes. I think, for every one success you have, you're probably having to work your way through 5 or so things that didn't quite go to plan. And that is the nature of this work. And I think people coming into it should have their eyes wide open. It's not just all celebratory and success. There's a lot of hard graft and a lot of trial and error. We've learned a lot of things the hard way. When we began in East London, we spent a lot of time focusing on our point of care staff, people working in our clinical teams, and our most senior leaders. And we paid very little attention to probably the most important group of all, which is the middle management, the sort of core leaders in the organisation. And we would definitely do that again differently, because whilst we had a lot of enthusiasm from people in patient-facing roles, and our board and our senior leaders were completely behind this, actually we had failed to really help the people who have the toughest job of all in the middle of the organisation from really understanding how would this help them in their jobs. That was a big lesson for us. We then had to really catch up and spend some time thinking about how to do that differently. We paid no attention to our data infrastructure at the beginning of this, and people started to apply QI and suddenly realised, well, where are we going to get this data from? Our data systems are archaic. And so, we spent the last 6 years now playing catch up, which again is if I was doing this again, I would definitely not do it that way. And, right at the beginning of this work, we sort of had an inkling that involving patients was the right thing to do. It felt like the right thing to do. We tried, we didn't do it very well. But only really after 3 or 4 years, when we looked back at our first 500 QI projects, did we learn that actually the projects that had involved patients fully truly co-produced the work from start to finish, they had a 2.8 times more likelihood of achieving their aim than all the other projects. That's a pretty profound effect. That odds ratio of 2.8 is significant. So there's not many factors that are that efficacious in this work. So we've had to learn rapidly how to involve people meaningfully and authentically in QI work, and we've got it wrong probably more times than we've got it right, but with the desire that we want to keep improving and try to do this as best we can, and we measure it now, so we have a way to actually know how many projects truly involve people in a fully co-produced way and how many don't. We're continuing. We're still an effort we are not as good at as we should be. So I think there's going to be lots of things, Naomi, that as you do this work don't go as you plan. I think the key is just to be mindful whenever you start something, that you've got a theory, that you've got a prediction, and just as you would in QI, you're reflecting as you go and you're adapting. And some things won't work, and you need to ditch those ideas and try some new ones. Some things might work a little bit, and you need to tweak them, but adopt the same principles of sort of iterative testing and learning that we do in QI projects to the actual way you do QI as a person, as a team, as an organisation, because there'll be lots of things that that don't go as well as you hoped.
The spaghetti test, see what sticks. Quite like that. It's a little bit of an analogy, really, in that learning cycle, as you're saying, when things don't quite go to plan.
This about brings us on to our last question now. So we've discussed some big challenges, and as you rightly said earlier, there is an amount of negativity about the NHS, but there is also a lot worth celebrating. And I wonder if there's anything that you'd like to share with us at the moment, either about good work that's happening, or even just ways of working that you're really excited to see and think that gives us a bit of cause to be optimistic.
Well, I am an eternal optimist, and I think a lot of improvers are really, that things can be better, and that between us we have the will and the ideas, and that QI gives us the method to make those come to fruition. One of the privileges of having this national role now has been the opportunity to go and visit and talk to people across the country, and I can't tell you how much hope and optimism that has brought me, because I've had the chance to learn about work that's going on in different parts of the country that I never even knew existed. And I thought I knew a fair amount about quality improvement work that was going on in England. But actually, you don't have to go very far in any part of the country to find really good, robust quality improvement work that is making a difference to people's lives. And that's what this is all about. It's about just applying a method, bringing people together, and making sure that we are leading in a way that gives people the autonomy to do this work. And that's, for me, that needs celebrating. It's hard because our attention is always drawn to things that aren't working so well, problems, and we're sort of inclined to be focused on that. But actually, we need to make sure consciously that we're paying as much attention to the things that are going well. And it's not something that will always be trumpeted about in the media, but there are some lovely stories and examples of teams, organizations applying quality improvement, demonstrating really impressive results, and people, both patients and staff, having a much better experience as a result. And that is lovely, really lovely to see. And I hope we see much more of that over the coming months and years.
Oh, you just reminded me again, the power of storytelling. And when we come together as a network and we're sharing, as you say, the great work that's happening, sometimes within your own area, you're not aware of it, and beyond. And when we see those linkages between the network and the power of that sharing that you touched upon, Joe, and the narrative of the storytelling, that it isn't always a published article, it's just sometimes that lived shared experience, which can be that real motivator that hooks people in and starts that change conversation happening. They're not to be underestimated, are they, in how we can come together as a community of improvers? No,
not at all. And so I guess my final message to people listening in will be, well, first, thanks for sticking it through to the end and hearing what I have to offer. But this can be a relatively lonely road for people. So I would say just make sure you have three things. One is learn the tools of quality improvement. There are ways to get really skilled in quality improvement now, which I think people should all be taking up the opportunity of, because it's a transferable skill set. It will be with you for the rest of your careers and your life. And there's a depth to this method that I think most people don't appreciate, that we could all be learning about. So go and find places to really learn from the best. Secondly, find some colleagues and friends who are on this journey with you, because you will want some people to turn to for support and guidance and advice as you do this work, because it's not easy work. You'll be facing challenges all the time in this work. And thirdly, just stay really close to why this matters to you. Make sure you're finding time to connect with the why, because that's what's going to give you the courage to keep going, even when the work's tough or you don't have time. Just really continuing to stay connected to the purpose of this. And quality improvement it can feel a little bit corporate, a little bit academic, but it's not really. It's about improving people's care, improving people's outcomes. And if you really stay connected to that, and you stay close to it, and you feel the impact that the work has on it, I think that will keep us courageous and keep us going.
Oh, thanks. That is a great place to finish, to take those three thoughts with us. Thank you ever so much for joining us here today. I found it really useful, and I think our listeners will as well.
Thanks for having me.
Thank you.